Good morning, everyone. My name is Jenny Lee, and I'm a doctor from the Department of Cardiology, affiliated hospital of Guangxi Medical University. So, today I will be your teachers who will teach your knowledge of our electrocardiography. So, before the beginning of the class, I'd like to introduce myself to you. Uh, I get my medical doctor degree at the year 2009 uh, at the Guangxi Medical University. So after the graduation, I worked at the first affiliated hospital of Guangxi Medical University as an associate professor. At the year 2019, I went to the University of Oklahoma Health Science Center at the United States as a visiting scholar. So after I come back to China, I joined the affiliated hospital of Guilin Medical University. So now I work at the Department of Cardiology. So there are four pictures here. Uh, this picture is my university. It is Guangxi Medical University. It's the first hospital I work at. And this picture is a photograph at the United States at Oklahoma State. It's the medical center of Oklahoma University. And it's my photo of my working place. I do the interventional operation for patients with arrhythmia. Okay, let's begin our lessons about the knowledge of ECG. So, what is this? Yes, it's a watch, right? Everyone know this is a beautiful watch. It's an Omega watch. It's very expensive, but I think that the reason for this watch, the price of this watch, is not because it has a good looking, right? But because what? We all know this watch has a good characteristic, that is accuracy, right? So this watch is very expensive because it has a very good accuracy. We do know what is exactly the right time, right? Um, it really has some mistake to show the time for us. Okay, our heart, our rhythmia is the same as the watch, right? So take a close look at this picture. This is our heart. We have electrical activities. So every minute, every seconds, right? So if there is some abnormal rhythms coming out, it would happen. What would happen? It will produce some arrhythmia, right? Including it has a slowed heart rate or it has a fast heart rate. So no matter it has a slow heart rate or it has a fast heart rate, we all call it arrhythmia, right? It's just like a watch. If the watch work at a little bit slow speed, the time is not correct, right? And also if the working speed is a little bit fast than a normal speed, right? It also so long times, right? It also so arrhythmia for us. So our learning purpose is to master the clinical manifestations, diagnosis, differential diagnosis, and also prevention of common arrhythmia. And second, we should get familiar with the etiology, classification, ECG characteristic and rational use of anti-arrhythmia drugs. And finally, we must understand the interventional therapy and surgical treatment for arrhythmia. So there are also some key teaching points here. First one, we must get familiar with the graphic and the criteria for us to diagnose a premature. So what is a premature? Can we diagnose a premature correctly? Right. So we must remember the graphic and the criteria of the premature. And second, we should know the graphic and the diagnostic criteria of atrial flutter and atrial fibrillation. And third, we should know the graphic and diagnostic criteria for supraventricular tachycardia and ventricular tachycardia, right? And fourth, we should know the patterns and diagnostic criteria of atrial ventricular block. Yes, there are 4 key teaching points here, right? And also some difficult points for us to learn ECG. The first one, that is the characteristic of common arrhythmia. And the second one is the drug therapy for arrhythmia. So there are so many drugs that can be used to treat the arrhythmia, right? But which one is the best choice? Which one is fit for the arrhythmia? So they are different, right? And they are also important. So if you use a wrong drug for patients, it would produce a bad clinical outcomes. Okay, this is the anatomy of cardiac conduction. This place, we call it a sinoatrial node, right? It has a node here, and this place is the atrial ventricular node. And then here comes the bundle of his here, over here, right? And then it's spread into 2 bundle branch. This branch is left bundle branch. This one is right bundle branch, right? So at the end of the bundle branch, it has Purkinje fibers over here, right? At the end of the bundle branch, which connect the bundle branch and the cardiomyocyte. Okay, and last, it has ventricular muscles. So this is the process of the ECG come from. It has electrical activities which come from the sinus node and then transmit to the AV node and then spread to the left and the right bundle branch, and finally it comes to the ventricular muscles. So that is the cardiac conduction. It's a complete cardiac conduction. It's normal. It's a normal cardiac conduction. Okay. So, what is the definition of a cardiac arrhythmia? As what we said, that cardiac arrhythmia means that an abnormality of the cardiac rhythm. It has an abnormal rhythm, right? So which one is abnormal is really important. And arrhythmia may cause sudden death, syncope, heart failure, dizziness, palpitation, and no symptom at all. And there are 2 main types of arrhythmia. So as what we said, right? If the heart rate is lower than 60 beats per minute, we call it a bradycardia. If the heart rate is faster than 100 beats per minute. We call it a tachycardia, right? Okay. But let me remind you something interesting. Some normal person sometimes has a heart rate slower than 60 beats per minute, but is faster than 50 beats per minute. Is it abnormal or normal? So we call it a normal heart rate because sometimes a normal person can have a heart rate which is slightly slower than 60 beats per minute, but normally the heart rate should higher than 50 beats per minute, right? Okay, we have a classification of the arrhythmia. This is a normal heartbeat, right? 1 beat, 2 beat, 3 beat, right? Every beat has a fixed interval. Okay, that is a normal heartbeat, not too fast, not too slow. Okay, and this one, we can see the heart rate is slowed down, maybe smaller than 50 beats per minute, right? Maybe just 30 or 40 beats per minute. We call it what? Yes, we call it a bradycardia. And this one, the heart rate is accelerated, right? To maybe 180, 120 beats per minute. So what should we call this arrhythmia? Yes, we call it a tachycardia. So understand it? Okay. This is a table about the classification of abnormal ECG. We can divide different locations for the arrhythmia. That means the sinus node, atrial, AV node, and ventricle. And we also have two types of arrhythmia, right? The first one is bradycardia, bradyarrhythmia. Second one is tachyarrhythmia, right? Tachyarrhythmia. So if the bradycardia come from the sinus node, we call it a sinus bradycardia. And if the tachycardia come from the sinus node, what should we call this arrhythmia? We call it a sinus tachycardia, right? And if the sinus node completely destroyed by some reasons, for example, by some toxic drugs or something, it would produce which disease? It will produce sick sinus syndrome, which including many bradycardia ECG or many tachycardia ECG. Yes. And the second one, atrial. So if the tachycardia come from the atrial, you can call it atrial perimeter beat, atrial flutter, atrial fibrillation, and even paroxysmal supraventricular tachycardia. Okay. And also, if there is a bradycardia emerge at the IV node, what would happen? It would produce a conduction block, including first degree, second degree, and even third degree conduction block. There you get it? Okay. So if a bradycardia comes from the ventricle, we call it a ventricular escape rhythm. And most of the time, if there is tachycardia come from the ventricle, it has a ventricle tachycardia and even ventricle fibrillation, right? So the classification is really important for us because including many kind of arrhythmia, but we can also divide them into many classifications. Bradycardia, tachycardia, right? That means the speed of arrhythmia. And second, we can classify into different locations, like sinus node, like the sinus node arrhythmia, like atrial arrhythmia, AV node arrhythmia, and ventricle arrhythmia, right? Okay, let's talk about the mechanism of arrhythmia. So I think that is a little bit uh, difficult for us. So I try to explain it in detail. So first, the mechanism of bradycardia. A sinus bradycardia is a result of abnormally slow automaticity, while bradycardia due to AV block is caused by abnormal conduction within the AV node or the distal AV conduction system. So can you understand it? The mechanism of generating tachycardia include three reasons. The first one, accelerated automaticity. The second one, trigger activity. The third one, reentry, circuit movement. Okay, it's a little bit difficult. First, accelerated automaticity. The automaticity is the mechanism for sinus node arrest or many premature beat, automatic rhythm, as well as an initiating factor in reentry arrhythmia. How can we interpret this knowledge, this statement? I show you the pictures here. So this is a car, right? Yes, it's a car, a usual car, and it's a normal automaticity. It's like a normal engine. We all know that a car only have an engine, right? The engine can give the power to make sure the car can work normally, right? But one car only have one engine. Okay, so if there is another engine coming out, we call it the abnormal automaticity. This engine can also give another power to drive the car move forward, but sometimes it would have a contradiction with the normal engine. You understand that? Normally, one car only have one engine, so it can be driven in a normal speed or something. But if there is another engine, let's interfere the normal working speed of the normal engine. It would disturb the speed of the car. You understand that? So we call it an abnormal automaticity. This is the first mechanism of arrhythmia. Accelerated automaticity. So including the sinus node arrest and also premature beat and also automatic rhythms like atrial tachycardia or something, and also some kind of reentry arrhythmia. We will explain it one by one. Okay. There is an abnormal automaticity at the junctional place, junctional rhythms. It can produce what? What you can see is that the heart rate is 60 to 100 beats per minute, and the rhythm is regular, right? 1 beat, 2 beats, 3 beats, the interval is regular, okay? But there is no P wave here. There is no P wave here, right? We can not see any P wave at least ECG. And we took notice that the QS complex is narrow, is normal. So what is the arrhythmia? What should we diagnose for this arrhythmia? We call it a junctional rhythm, a junctional arrhythmia, because there is an abnormal automaticity at the junctional site, maybe at the AV node or something. So it can produce another rhythm for this patient. But this rhythm does not come from the sinus node, but come from the junctional place, like AV node or something. So we call it a junctional abnormal automaticity. You understand that? Okay, the second one, the second mechanism of the tachycardia is a trigger activity. It has a trigger activity. So the myocardial damage can result in the cell potential at the end of the action potential. So this oscillation, which called the after depolarization, may reach threshold potential and produce an arrhythmia. And the abnormal oscillation can be exaggerated by pacing, by electrical disturbance, and by some medications. So examples of atrial tachycardia produced by digoxin and the initiation of ventricular arrhythmia in the long QT syndrome. So how can we interpret this statement? Okay, we all know it's also one car here. It only has one engine, right? It only has one engine. Okay, it's a normal automaticity. There is no other engine but one engine. This engine is normal, but we took notice that there is a trigger here. What is a trigger? It has a fire. A fire can accelerate the working speed of the normal engine. So it can accelerate the car. You understand that? Let's compare to the analogy of this picture. Okay, it has one engine. It has a second engine. So we call it abnormal automaticity, right? And this one, only one engine, but has a trigger like a fire. It can accelerate the working speed of the normal engine. So that is the second mechanism of tachycardia, trigger activity. You understand that? Okay, here's the example of the trigger activity. The first one here is a normal action potential. And it consists of 5 stages of the depolarization. The first stage is a 0 stage, right? Stage 0, stage 1, stage 2, stage 3, and stage 4, right? So if there is a trigger activities coming at the stage 2, we call it a phase 2 after polarization, after depolarization. The depolarization is the stage 0 and stage 1. You understand that? And the stage 2, 3, 4 consist after depolarization. So if there is a trigger activities coming out at the stage 2, we call it a phase 2 after depolarization. Understand that? And if there is a trigger activities coming out at phase 3 after depolarization, we also call it a phase 3 after depolarization, and so on. If there is a trigger activities coming out at the stage 4, we call it a phase 4 after depolarization. Right. understand? Look at this ECG. Yeah, at the beginning there is a normal potential here, right? Normal QS complex here, but at the end of the T wave, what happens? It has a big QS complex, right? It has activities at the state what? Maybe at the state 3 or state 4. So at the end of the depolarization, there is another trigger activities coming out. There is another potentials coming out. So we call it trigger activities. You understand that? Okay, the mechanism of the tachycardia is reentry. For reentry to occur, there must be an error of unidirectional block. It has a unidirectional block with an appropriate delay to allow repeat depolarization. Pay attention to this word, repeat depolarization. Here's a circuit here. Is the beginning of the potential, the beginning of the activity, right? And coming from the left to the right, from the right to the left, right? And then, okay, come back to the beginning of the potential. So it emerges a circuit reentry activity, right? So this is the normal activities and normal. So most of the time it only have one activities from the top to the bottom, and this place has a unidirectional block. You understand that the potential cannot transmit from the top to the bottom through this place. But if there is a potential at the first time, the potential can spread from the top to the bottom through this from this path, and let some potential can go back right, to the beginning of the potential, and then it also can produce another second potential from this path and transmit it again. So here would produce a reentry activity. It can repeat continuously, so we call it a reentry tachycardia. You understand that? Okay, there's another fingers showing what is a reentry tachycardia. At the top is the atrium, right? The middle one is the AV node. Yeah. Below it is his potential, his bundle. Okay. So if there is a potential come from the top to the bottom from the fast path of the AV node, it can produce a QS complex, right? Only one QS complex can be produced by this activity because no potential can go back or no potential can go through this place, right? There is a unidirectional block here. And second one, if the potential come from the top to the bottom through the slow path, it also can produce one QS complex, but the P wave and the QS complex, the PR interval should be prolonged, right? Because the speed, the transmit speed through the slow path is really slower. Okay. But if there is potential come from the top to the bottom through the slow way, and then it can go back through the fast way to the top, what would happen? Okay, it has a normal P wave, and it has a long PR interval, a QS complex, and very importantly, it has an atrial echo. It has an atrial echo here. That is an atrial wave here because there is some potential can go back from the bottom to the top, right? So it has an atrial echo here. Really interesting. And sometimes, if this activity repeated one by one, what would happen? It will produce a tachycardia, right? Many QS complex will will emerge here, right? Because the potential can be produced one by one at a circuit here. So we call it a reentry tachycardia. Okay, like this car, a car can drive from the left from the right to the left, but it just drive at a circuit, so we call it a reentry tachycardia. Okay. So if there's an EKG in front of us, what should we do? Should we diagnose the ECG directly without any kind of informations? Obviously, before we diagnose an EKG, before we diagnose what exactly ECG, I think there are many informations we should collect, because some information is really important, is helpful for us to diagnose an ECG. So there are so many approaches to diagnosis arrhythmia. The first one is the history of the patient. When does it happen? How did it happen? Right? How long does the ECG, the tachycardia sustain, and how did it begin or how did it terminate? Is really important. And the second one, we should do physical examinations for the patient. For example, we should hear whether it has a heart murmur or not, and which kind of heart murmur. Is it a systolic murmur or diastolic murmur? And sometimes the patient has a right side heart, right? You know that the heart is located at the right side of our chest. It's not at the left side of the chest. And we must do some laboratory examination for the patients. Which examination? When should we do? There are many information we should get before we diagnose ECG. History. The history including the chest comfort, like palpitation, like dyspnea, syncope, and dizziness, and even syncope. And we must note the history of the heart rate and the mode of starting and the mode of termination of the arrhythmia is really important. And what is the consequence of the arrhythmia if it come out? And a physical examination including what is the heart rate, what is the rhythm, what about the heart sound, and even the heart position. And we should do the atrial pressures for the patient. And we also do the junctional venous pulse and also the text of carotid sinus massage right? Because this massage can slow down some kind of arrhythmia, like it can slow down the supraventricular tachycardia, but it cannot slow down a ventricular tachycardia. So this physical examination is also important for us to diagnose this ECG. Okay, which laboratory examination should we do? The first one, to tell read ECG is important. It's the most used examination for patients with arrhythmia. Sometimes we should do 18 lead ECG for patient, like we try to diagnose this myocardial infarction, maybe at the right side half of the myocardial infarction, right? So sometimes we have a posterior wall of the myocardial infarction. We should do the 18 lead ECG for patients. And we also can use the Holter recording for patients, because the Holter recording can monitor the rhythm over 24 to 48 hours. And sometimes we use the esophageal ECG for patients, because it can be differentiate supraventricular tachycardia from ventricular tachycardia, and it also can define the mechanism of supraventricular tachycardia. And sometimes we can use some exercise testing to watch what will happen to induce various types of tachycardia or bradytachycardia. And finally, we can use the intracardiac ECG for electrophysiological examination. We proceed some electro leads into the heart, and we do some programming stimulations to induce the arrhythmia, and then to diagnose it correctly. So this is the first class of our ECG. See you next time. Bye.